Okay, apparently we are live. Okay, good evening, everyone, and welcome to a UCLAN event, which is a CPD event around how we manage the COVID pandemic in our dental practices. The audience, I think, is spread amongst general dental practitioners and DCPs and undergraduate dental students and therapists. Welcome all. You may or may not have seen the many guidelines which have been published recently from the BDA, the Faculty of Dental Practitioners, the periodontists have had to go, the endodontists have had to go, etc. There's a plethora of guidelines out there for you to read at your leisure and potentially confuse yourself. So what we're want to do today is to put some sense to those documents, put a little bit of science behind them and maybe clarify some of that science and debunk it somewhat. And also to look at how we can put these guidelines into practice in our practices easily and conveniently. So we're welcoming here this evening myself. I'm Ian Byrne. I'm lead for the BDS program at UCLAN. And I'm no expert whatsoever in this subject, so I'm just chairing the meeting. We have Carl Horton, who qualified at Birmingham in 1996. Carl, am I right? You've got a bacteriology background as well?
I did microbiology at Preston many years ago. Yeah.
Okay. So a little bit like the undergraduate students, we have a postgraduate entry. But since then, he's gained a master's in perio and in implantology, and now has a practice specializing in these subjects. And you've lectured internationally, let's say. Yeah. We also have Chris Tavares, who qualified in 1984 from Newcastle. You'll get over it eventually. His special interests are cosmetic dentistry and prosthetics, especially complete dentures. A rare animal, I might suggest, Chris. And you're basically a single-handed practitioner who has a hygienist and therapist to help you in that endeavor. And you have converted your practice to follow the guidelines in a practical way, but that sums things up. Okay, good. We're also welcoming as well a local professor in immunology who teaches at UCLAN, Anthony Lewottom, and is clinical director for Lancashire and South Cumbria in the Department of Pathology, and basically is an expert in immunology and will hopefully enlighten us as far as the testing process is concerned. Thank you. And well known to everybody, I'm sure, we have Professor Cynthia Crean, who's Pro Vice Chancellor at UCLAN and consultant in oral maxillofacial surgery. Difficult to say. Okay, so without further ado, we're going to start with Carl, who will hopefully give us some scientific background, and then we'll move on to Chris, who's going to give us the more practical aspects, and then hopefully we'll have a question time where everybody joins in and we'll find out about testing, etc., etc. Does that sound reasonable, everyone? I will be keen to watch the clock because we don't have very much time. We're here for an hour, and I think we should stick to that if at all possible. And I can be a bit of a taskmaster, so so Carl, if you wouldn't mind making a start, that would be great.
Thank you very much. Thanks, Ian, and thanks everybody for joining. I'm just going to bring my screen up now, so you should be able to see my presentation, and then we'll make a little start. I'm glad Ian's timing me, because the last time that I did this presentation, I expected it to take 10 minutes and it lasted about 50. And I do apologize for the panel that were with me on that day. I certainly won't do that this evening. So as Ian mentioned, I've got a background, very small background in microbiology. And what I've been doing since we've all sort of been at home is sort of analyzing about what's been going on and looking into the details. One of the things that intrigued me was the mask situation and masks and respirators, and certainly the aerosol situation. And as that developed into the aerosol generator procedures, really why we were being told what we were being told. And my brain is to sort of find things out. And obviously we had plenty of time. A few things have happened to me along the way. I'm pretty sure that I caught COVID. I certainly had all the symptoms, and yesterday I had a little test at Birmingham Dental Hospital to find out. It was certainly an interesting experience. Probably a little bit different to the SOPs that you're going to be doing in practice, but pretty good. It's nice to see a few faces. I used to teach there. But basically what we're going to go very basic, and then we're going to come and expand a little bit. So the principles of the protection with the masks are, as we understood them, to primarily protect the wearer, and the respirators, two-way protection. So we're protecting the wearer and the patient unless they're valved. And I've put two little eyes here because what the interesting things that these don't protect unless you've got a full face respirator are your eyes. And there is some research out there that would suggest that there's a possibility that we might be at risk of developing infections from the through the eye, going down the lacrimal gland and into the nasal area. But that's up for debate. This little table here, what this does is it was something that I sort of was helped put together with to kind of understand the difference in the masks. Because as far as I was concerned, when I went to the practice, there was a mask that I popped on. It was a surgical mask, and I was quite happy with that. I knew that the respirators existed, but before COVID, I didn't really feel that I needed to wear one for a patient. I'm not so sure that I do feel that I need to wear one now, but that's for debate, and we can talk about that. So we've got the single-use mask, and I've put a little picture there to sort of suggest how I might feel about those masks. And these little examples here, you can see BFE, which is the bacterial filtration efficiency of 3 microns, and then we're looking at about greater than 95%. But in the UK, there's no particle efficiency requirement. And then we come down and we've got type 1, type 2, and type 2R, with the R meaning that we've got some water resistance on those. And I've colored that in green to go with the Nando's scales of the COVID level that we're looking at. So that's what we're probably hopefully getting down to when we're back to the new normal. And again, I don't particularly like that word. So we've got difference in the filtrations again there. It's sort of going up from 95% to 98%. And then the Americans have a little bit more of a standard on that one. We don't really have that over here in Europe, but they put a standard on the particle filtration efficiency. And again, we're going 95, 98% down to 0.1 micron. But as we understand these, and the principle behind these is that we've got spaces around there, which allows these nasty, awful, infective, killing aerosols to get through. So based on that, they're obviously terrible, and we should all be using respirators forevermore. So we've got different types of respirators, and there are various types, and this should help us just understand them a little bit, because I've been asked by lots of my colleagues, and I've certainly seen it on social media. There seems to be lots of questions about this, and I think as we're going through this, we're sort of getting some idea of what we should be sort of looking at as the guidelines go forward. So I've put FFP1, FFP2, and FFP3. And what we're being advised really is the gold standard is the FFP3, which has a 99% efficiency rate at 0.3 microns. And then we've got the other ones that are either Chinese, which is the KN95s and the N95s. And there has been a little bit of a concern about the fits on these. And some people have said they've really struggled when it comes to the fit tests, and some people have said they haven't. And certainly I've had some people report to me they've had some problems with the KN95s, but that was more because they have little ear loops rather than ties. So it seems like the tie-back ones seem to work a little bit more efficiently. But the problem is actually getting hold of these things now, and obviously they're in demand and they're in short supply. So I'm just going to come back to masks a little bit and how that filtration works. And we've got something called a melt-blown layer, or a material layer that goes sort of in between. And what this is, it's a polymer that's been heated up, and then it gets blown onto a cylinder, and then that sort of folds over like a material, and then they cut that down and they put that in between the mask. And this is able to cause some filtration effect on the masks. So that's the type 2 masks. When we come to the respirators, we've got the N95s and the FP2s, and they're pretty similar and fairly equivalent. There's a slight difference in the standards, but for all intents and purposes, they've got a pretty much similar effect on their filtration ability. And then we've got the FFP3 and the N99s, which are the step above, and you're looking at a 99% filtration efficiency. So you probably, like me, you have to ask yourself, what's the difference in that? And really, is that going to make a huge difference to your safety and your staff's safety in real terms? And judging by the comments that are coming through HSE and Public Health England, I think that that's negligible. And they've actually said that if you can't get hold of an FFP3, then an FFP2 is fine. That's in this country. In other countries, they're saying that a surgical mask is fine when we're looking at those awful aerosol generating procedures that we do. So it's just interesting to bear this in mind. I do talk a little bit about valves and not non-valve, but I'm going to let Chris talk a little bit more about that. And then we've got the coronavirus, and why do we have this sort of 0.3 microns as something that's sort of banded around on these masks? And that's because this size, this particle size, it's the most penetrating particle size when it comes to these masks. So what that actually means is at 0.3 microns, when they've studied the filtration effect, it's this particle size that will get through that layer of filtration the most. And the interesting thing is the coronavirus, it's quite a big virus as things go. And Anthony will talk more in detail about that, I'm sure. And that virus is obviously smaller than that. But the interesting thing is smaller particle size than this actually is filtrated more efficiently by the respirating masks. And that's because it follows a random motion or a Brownian motion. And these masks are also charged as well. So they've got an ionic charge on them. So as you're breathing through, these little particles that are coming through, if they are infective, will actually get caught by the respirators. So they actually filtrate more efficiently at a lower diameter than a 0.3 micron. So that's how they work. You can get them fluid resistant, and in my opinion, if you are going to purchase these masks, you do want them to be fluid resistant. You can have them valved and non-valved, and the important thing about having them non-valved is that when you're breathing out, your air is not going towards the patient, but you can sort of adapt to that by putting a mask over the top, and Chris might talk a little bit more about that. They should all be fit tested, because otherwise you may as well just wear a surgical mask. The whole point of having them fit tested is so you get the seal. I've had a fit test today, which was very interesting. It's a horrible tasting substance, and Chris can talk you more through that as well. And then they need to be comfortable. So when you do go for these fit tests, you need to be talking to the person that supplies these masks and finding something that's comfortable. Usually these fit testers come with a series of masks. So masks and respirators, the evidence for both of them in terms of their protection, it's actually weak. And there are studies out there, and they're not great studies. They're sort of fairly decent in some respects, but not very strong. There's a lot of weak evidence out there. And they've done comparisons between N95 masks and surgical masks at preventing infection. I know the infection was sort of influenza, so it doesn't really relate in terms of the disastrous sort of pandemic that we're having, but in some ways it does. And these are the only studies that we have to sort of look at. And what these studies sort of show is that these masks, these N95 respirators, have a similar efficiency in a surgical mask at preventing infection in humans. And what they also did is they looked at these surgical masks against people that didn't wear them and the incidence of influenza between the two. And what they saw was the surgical masks were actually very, very effective. So there's actually very little difference in terms of when it comes to influenza between a surgical mask and an N95. And I think that's quite an important thing to bear in mind. Now, I'm going to talk a little bit about aerosols, not in too much detail, but I just want to sort of make some important points that sort of not coming across possibly from some of the authorities that we're hearing. So we've got these respiratory aerosols. So when we talk about aerosols, it's not just the dental aerosols that we produce, but they're also aerosols that we produce from our respiration. And what we know is people are always emitting these aerosols when they're breathing. So unless they're dead, they're not really producing these respiratory aerosols. And it depends on the individual. So everybody's slightly different. So now as I'm talking to you, I'm a little bit excited and I'm speaking fairly loudly. I'm raising my voice so that you can hear me. I'm not coughing or sneezing, but because of this, rather than my normal tidal volume, I'm actually producing more aerosol. Now, we can't see that. I'm hopefully not splattering on the camera, but that's changing. And people have loud voices. People are very quiet. People breathe differently. So there's a difference in the individuals on how much of an aerosol they actually produce. And we don't know whether these are infective or not. We know they're infective in aerosol-borne diseases such as TB or measles, but in SARS-CoV-2, we're not really sure that it's spread by anything other than droplets and formites. So there's no viable virus proved in aerosols when it comes to this. And so what we know is that it's droplets, formites, and contact. So the formites where we're touching the door handles that may have been coughed on, or from our hands and we've touched it again. Contact between shaking hands on somebody that maybe has sneezed on the hand and then making that touch your eye or touch your mouth. So the information that we're getting about washing your hands seems vitally important, and also not touching your face. That seems to be a huge sort of stopgap in the spread of this infection. And so that's one side of the aerosols. The other one are the dental aerosols and the definition of what's an AGP. So that's sort of come down to the use of an ultrasonic, a handpiece, and 3-in-1. And there's been some more recent SOPs coming out about what you can and what you can't do. So I think the British Society of Periodontology have just confirmed that you can polish a patient, and that's not regarded as a dental aerosol. And also, if a patient has a cardiac emergency in your surgery, then you can provide CPR, and that's not regarded as a dental aerosol. Obviously, it is an aerosol of sorts, but I'd rather you kind of save that person than worry about getting your respirator out. So what's the evidence that these dental aerosols are a danger? Well, there isn't much, if any, to say that they are a danger. And what we know about these aerosols is what we think in terms of them being a danger is because what happens is when we're creating these aerosols, they're mixing with the patient's saliva and blood. But some of the things that are coming out from that are what we call the splatter, these droplet nuclei, and this sort of produces what we call this aerosol. And it's that splatter that we think is going to be the most important thing that we need to worry about. So wearing a visor and a face mask, we're going to reduce that a huge amount. These droplet nuclei that are being formed, that are going up into the air, well, we can actually protect ourselves from those with using high volume aspiration. This is a study that's ongoing at the moment, and this shows how effective this high volume aspiration is at mopping up those aerosols completely. And we're looking at about a 90 to a 98% reduction in the aerosol production when high volume aspiration is used. So aerosol generated exposure is probably a better term to use when we're dealing with patients, certainly in the dental side of things, because we've got the patients breathing, and then we've got what we cause in the surgery by actually doing the generation ourselves. So how can we lower those perceived risks? And this is what we're sort of being guided towards, and it's triaging the patients. So we've got the alert level and we relate it to the R number, and if that's below 1, then we're all looking good. Then there are some treatments that have been advised, such as mouthwashes. So chlorhexidine was thought to be sort of effective, but what we know is that's quite good at bactericidal, but it's not very good at being virucidal. So we've looked at hydrogen peroxide or povidone iodine, but the research that's coming out is sort of suggesting the problem with that is it gets washed away quite quickly within a few moments. So as you're scaling your patient or you're drilling in your patient's mouth, that's being replaced by the saliva. And we don't really understand how much that virus is in that saliva. And also, don't forget, those patients are still breathing. This is constantly happening. Then we've got the high volume aspiration, which we can reduce. Rubber dam, we're looking at about a 98% efficiency in reducing these aerosols. And then we've got coming on to ventilated rooms, and we can discuss this as we go along, and ventilating rooms. And there's all sorts of downtime that we're talking about that's being banded around. I mean, all rooms are pretty much ventilated to some degree. You've obviously got the windows that you can open. If you're downstairs in the basement, there's no windows. There has to be some sort of airflow going in that room, otherwise we'd cook in the rooms. And then we've got aircon, which originally I think it was being talked about not being used, but now we're being told we can use it as long as it's non-recirculating aircon. And then we've got these air purifiers, which the evidence is a little bit, again, weak, but it's something that might be able to help us sort of going forward. And I certainly think as the perception to our patients, which is really important about what we're doing, is that we're a very sort of safe place. We always have been a safe place. You know, the evidence, as I mentioned earlier, of SARS-CoV2 being in aerosols, it just doesn't exist. And even, I think one of the people today or yesterday tweeted that her research where people were taking that and suggesting that it was in an aerosol, she actually said, well, actually what we did is we artificially produced that in a drum, and that's how we got the virus out. So again, it's not sort of backing up that virus is actually in the aerosol that we're producing. And again, in these aerosols that we are producing, a lot of the time we've got some antimicrobial substance within the dental water lines, usually, to prevent the biofilm. It doesn't completely prevent the biofilm, but it does help. You've got all sorts of other things in there, oil and everything else.
For time.
Yeah. Do you want me to hurry up?
Please.
Yeah, so we've got universal precautions. What we know is universal precautions have worked very well. When we look at the evidence of dental workers showing issues, then we're not really seeing any evidence that they've shed an increase in COVID for us or all of our patients. We're not seeing any hotspots when it comes to dental workers. And then what we've got is a nice little summary here. We're being sort of inundated with all sorts of SOPs at the moment. So I've come with the top 10 SOPs that you can sort of see here, and we've got number 10 FDDP. Actually, this isn't any particular order, I've just made this up. And then we've got European Federation of Periodontology, BDA, the Office of the Chief Dental Officer, British Endodontic Society. Shalina, put that one in there for you. We've got Portman, and we've got the BSP, and then again we have the Remix, and then My Dentist. But I think the important thing is that you've got to do it yourself. So you pick one of these, stick to it, have a look at it, adapt it to your own practice, and then go forward, and we're all going to be good and we're all going to be fine. Now I'm going to end it there, and I'll pass back over to Ian, and the room is now yours.
Thank you very much indeed. That was very well done, very succinct, well done. So can we ask Chris to come in at this stage and then put some practical meaning on those scientific facts?
Right.
Thanks, Chris.
Good evening, everybody. For those of you who arrived late, my name is Chris Tavares. I'm a general dental practitioner, single-handed in private practice. And I've been asked to share with you two things today: the standard operating procedure and the difference between an FFP3 mask and a half-mask reusable respirator. So we'll talk about the SOP first. In the last week, for those who are not in primary care or who don't own a practice, it has probably been one of the most stressful time in dentistry's life, because, as you know, we only found out giving about 10 days when the practice was allowed to open. And you cannot open unless you have made up a standard operating procedure for your practice. And there are many of them available, as Carl has already shown you. And what was happening with the people were panicking. And don't forget, the Chief Dental Officer, the Office of the Chief Dental Officer only released their SOP on Thursday, which really gave NHS practices 2 working days and a weekend to prepare their SOP. I mean, that's just impossible. When people are panicking and they're rushing around, and if you go on Facebook, people are emailing me saying, you know, what do you do? How do you do this? And everybody went sleeping. So I'm going to try to go over with you how to set up your SOP in the least stressful way. The standard operating procedure is about how to minimize the risk of a patient passing the virus on to the staff passing the virus on to the patient, and the patient passing on the virus to each other. Okay, that's what it's all about. And there are many versions of that out there, and people be very, very generous to share it with you. However, the late Cardinal John Henry Newman said, "Nothing will be done at all if a person waited till he could do it so well that nobody could find fault with it." And that was a problem happening all over the country, because everybody was they were looking at all the different SOPs, trying to take bits and pieces out of each one and form their own perfect one. And as they did that, they were getting more confused, more anxious, and they were completely, after 2 or 3 days, they weren't getting anywhere. So my advice basically is this: you should really only choose one and you run with it. Now, to practice legally, you need to have indemnity. So I phoned my indemnity company up, Dental Defense Union, and I says, is there any particular SOP that I'm supposed to follow? And the answer was, as long as you follow one which is from a recognized authority or organization, we will defend you. Now, what does that mean? Obviously, your best friend down the road is not going to be seen as a recognized authority. However, one from the Office of the Chief Dental Officer would be a recognized authority, or the one from the FGDP, Fellowship of General Dental Practitioners, that would be a recognized one. Now, I'll tell you why I have gone with the FGDP one. When you set up the, what basically the SOP is about is from the time you make an appointment with a patient to the time they leave your practice, go home, exactly what are you going to do and what is your staff going to do, okay? And the mistake with everybody trying to form one perfect document in one like 60, 70 pages long is that everything will just cram together in a big mass, okay? So my suggestion basically is your SOP is going to consist of 7 titles, okay? So you take one, I've taken the FGDP one, and out of 7 pieces of paper, the first one you label staff. The second one you label communication. The third one you label the day before. The fourth one you label arrival. The fifth one you label treatment. The sixth one you label exit. And the 7th one you label after treatment. When you have these 7 things together, you take the SOP and you read it from page 1 and you read through it. And then as you read it, you will find the relevant bits to fit into these 7 pieces of paper, and you separate them so you don't get confused and all messed up, okay? Now, why I like the FGDP one is that there is very little preamble rhetoric, okay? There's anything they say is just relevant. They don't give you the whole history of how the virus spreads, how the droplets are. They get into business. And as you read it from page 1 to page 68, I think it is, you will find that the FGDP one is not to give you, does not give you the answer. What it does is it leads your mind on a journey of mental journey of logic, reason, and information. And at the end of it, when you read through it and separate all the bits into those 7 pieces of paper, you will find not only will you know what to do, you will understand why you have to do these things. And more importantly, in understanding why you do these things, you will come to have a very mental peace in your mind. You're not troubled at all. And mentally, you're actually prepared to start work rather than trying to think, oh, what do I have to do? What do I have to do now? You know, you don't have to remember these things. It's all logic, and it just follows one thing after the next. So staff, when you're reading through the FGDP one or any other SOP you decide to use, you have to educate your staff. You have to screen them like everybody else. So that bit comes in there, okay? Page 2 is communication, and basically means that when you first let the patient know that they're going to have an appointment, you have to tell the patient what to expect. Okay, that's very important, because the last thing you want is for a patient to turn up and you ask them to put a mask on, and they say, I'm not putting that thing on. And there's an argument there that, you know, and this is a true thing that's happened on Facebook. Somebody asked for advice, whereby I think the mother was going to bring the son to the dentist, and they sent out the instructions. And on the phone, he says, I'm a scientist, and these masks doesn't really make any matter. I'm not going to wear it, you see. Now, the last thing you want is for that to happen at the door during the appointment time, and all hell breaks loose. So communication means, as you read the SOP, write down exactly what you're going to tell the patient, what's going to happen, how they should do things, what they should do before they come to the practice, like go to the toilet, because the toilet's not going to be available, everything. That's communication. So as you read through the SOP, you see the relevant bits, you put it in there. Then the next one is the day before. So the day before means you, as a clinician, will phone the patient up, because the whole idea of minimizing the risk is that you lower the time the patient spends in that building to the absolute minimum. That's the whole idea, okay? In case there's some virus virions in the air. So the day before means you phone the patient up and you're going to go through the general chit chat. Hi, how are you? Are there any problems? So patient complains of that. All that stuff is done on that day. And the patient talks to you about what the problem is, and at that moment, you also do the COVID screen to just check that they haven't got the virus, obviously, yeah? So all that's done. Now, very often patients that say, my son, blah, blah, blah. Well, you can't do things like that in the surgery anymore. So you say to the patient, well, is there anything else you want to talk about it? This is a good time to do it. So that when they actually arrive at the surgery, that's the absolute minimum you'll be talking. Obviously, you do a little bit of chit chat, but you don't really want to be having taking the history of the complaint or the medical history and everything. So the day before, as you read through the SOP, you see the relevant bits you're supposed to do in terms of talking to the patient, what you're supposed to be doing. Then arrival is the next page. That's very, very important. What exactly are they going to do? So door's going to open. You're going to test the temperature. Your staff is going to screen them for the COVID screening questions. Then you're probably going to ask them to wash their hands. And what you then do is in our practice, they won't be sitting in the waiting room. From that moment, once they've been screened, they will go straight into the surgery. So that is arrival. What do you need to do? And as you read the SOP, you will see the relevant bits that's relevant for what to do when the patient arrives. Put that information into that box, that page there. Then the next page is treatment, which is the big one, because as you're talking to the patient the day before, you will already be carrying out the risk assessment, their age, their medical history. So are they high risk? Is this going to be aerosol generated procedure? Is not aerosol generated procedure? So once you come off the phone, you would have an idea that at 9 o'clock, Mr. So-and-so who's coming in is non-aerosol procedure. Therefore, this is the PPE we will wear. That's what treatment is all about. And you lay that, and all that information you will get from the SOP, and you put into that page there. Then exit is when you finish with the treatment. How is the patient going to get out of the door? Which door are they going to get out of? So you write that down and you separate that and pigeonhole that. So in our practice, the patient will get up and they just go straight out. Because on the day before conversation, we would have said that we won't be taking any money from you. So you either pay by credit card, over the phone, or back, or whatever you want. So that one is the exit. And then the final page is after treatment. How are you going to take off your PPE? How long is your fellow time and everything? So when you've done that, you will come up with 7 short documents of exactly what you need to do. Rather than the 80-page one document, you just going strolling down, separate everything, and you will find you have everything you need to do for the PPE. Now, if you are an NHS practice, then you have to follow the standard operating procedures of the Office of the Chief Dental Officer. I'm afraid anything, because she is basically in charge of NHS. As private, we have a little bit more leeway. We are, in a sense, regulated by the Care Quality Commission, so we have to prove to the Care Quality Commission that private practices are safe. So therefore, if you are following the Faculty of General Dental Practitioners, it's very highly unlikely they're going to say that SOP is rubbish. And for those of you who don't know this, and I hope you never experienced this, is that if you are ever called to a fitness to practice hearing on the General Dental Council, then the standard of care that you are going to be judged comes from the Faculty of General Dental Practitioners. So they are one of the big players in the game. And so is the Office of the Chief Dental Officer. So at the end of the day, it's a very reliable one. But the most beautiful thing about the FGDP one is it helps you to think through what you're going to do. So, for example, the fellow time, they will tell you that it's 1 hour. However, you have mitigating factors which can reduce that. So rubber dam, as Carl already mentioned, rubber dam, high volume suction, and if you had extra oral suction, you can then reduce that time. So and you can justify that. There is no evidence, okay, at the end of the day. So if you are challenged, then you need to produce a logical argument to say that, as far as I'm aware, I believe that we can reduce our fellow time to 15 minutes. And if you can produce that, that's fine. So that's all you need to do, really. But there's no evidence either way. Okay. That is all I have to say about that. So basically, what you take home is don't stress out over the SOP. Don't try to take 6 or 7 of them and try to take the big pieces out of it and produce a perfect one. The main thing is, this is all new to everybody. Don't try to be perfect. Produce your document, and then you can revise it as you go along. And hence, you don't see too many patients in the first week. That's what I would say. So, excuse me. Okay, I've been asked to talk about the the FFP3 mask. What I'm going to do is to compare the FFP3 mask with the half mask reusable respirator, and you will find that the half mask reusable respirator wins hands down. Okay. So first of all, you need the what is the difference between fit testing and fit checking? First, because these two words are very important. Fit testing is a legal requirement of the employer to make sure that that mask that you wear, the FFP3 mask, you can test it not to fail. Fit checking is just best practice. So either the employer or the employer pays somebody, an expert, to help to fit test it, and that usually happens when you purchase the mask. So they test that particular mask is right for you. Now, one of the reasons my fitter, who is very, very thorough, two reasons why he says, number one, masks fail, or you've seen photographs of people that they're all bruised. And some people say, oh God, I'm fainting, you know, I don't feel well at all. And he says, one of the reasons is that whenever you wear, you're not supposed to wear that for more than 1 hour at a go. Technically speaking, you should remove that, have a drink of water or something, and then put it back on. Okay. And the problem with the FFP3 mask is once it's fitted on, the question is, how do you know the seal, the integrity of the seal is intact? Okay. And the problem is people are wearing it. You've read the newspaper. Some people are wearing it the whole 3 hours, some of them the whole day. No wonder they start feeling not very well. And the other problem really is that people are over tightening that mask, because inside the mask, you see there's a rubber seal, and if you pull it too tight, the whole idea of the rubber or silicone seal is that it's supposed to mold to your face, and that's what the seal is. And when you tighten it too much, you push one end more than the other end, it breaks the other seal. Okay, but so if you are going to use an FFP3 mask, don't over tighten it, and be aware that the unpleasantness of wearing it will increase after the first hour. So fit testing, what does fit testing occur? What does it involve? And then after that, I will show you and the demo the actual respirator which we will be using in our practice. Fit testing basically involves 7 stages. And at any time, if you fail any of those stages, the tester goes back to the beginning. Okay. So the first thing that the tester does is he puts a hood over you. It's a clear screen, and he squirts atomizer or horrible tasting liquid. And the idea is that when you breathe normally, you don't inhale loud, you just breathe normally. And then when you taste it, you put your hand out. So for me, I started, and there's no doubt you will taste it, by the way, it's awful. The minute you taste it, you put your hand up and he counted 10 squirts. So there's your baseline of the test, okay? And when he then tests it for the next 6 exercises, he will probably spray between 10 and 15. So the next thing he does is he's showing you how to put your mask on, or in our case, the respirator. We put it on, he'll say, is it sealed? And we will say, yeah, as far as I'm concerned, it's sealed. He puts the hood back on, and you stand there and you breathe normally, and he starts squirting. And he normally squirts around 15 times. And if my hand doesn't go up, we go to the second test. This is where I would then have to move my head up and down, and he's still squirting away. If I pass that test, then I have to move my head left and right. If I pass that test, all the time he's squirting in that, then the next test I have to do is he gives me a passage. It's quite a long passage to read. Okay, so like you talking to the patient. And after that, if you pass that test, then you have to do 10 squats or bend over and touch your knees 10 times. It's like an exercise, it's like being in the gym basically. Then after that, he stands up and he squats 15 times again. And basically, what that is trying to simulate is all the motions that you will be doing when you are treating a patient, and hopefully that seal does not break. Okay, and if you pass that, then you know you've made it. Okay. Now, one of my staff actually failed up to 7 exercises. She failed on the 6th one, and he says, "Right, we're going to start from the beginning again." And so he asked her to take the hood off, and just from looking at it, he could say, "There's the gap just there." He just readjusted it, and straight away, she passed it. Okay, so that's the test. Right. If you are wearing an FFP3 mask, there are 2 types. Okay, one is a complete closed mask, and the other one has a valve in it. And the difference basically is this: with a closed one, when you breathe in, obviously the filters will filter out the virus, if you like. But when you breathe out, your exhaled breath doesn't go anywhere. It stays in that mask. So you can see what's happening is that as you are wearing that mask, carbon dioxide is building up. You try to wear the mask all day, you're going to start feeling dizzy. And the other problem with the mask is people can't hear you, because this is what you will sound like to them. They can't hear you. Okay. The other FFP3 mask has a valve in it for the exhaled air, and that's a little bit easier to breathe in. But the problem with that is, as Kyle said, your breath, in case you are a carrier, is going to go onto the patient, and therefore you have to wear a fluid-resistant surgical mask over that valve to filter the air as it comes out. However, this will win hands down. This one is a 3M half-face respirator. Okay, there are 7 reasons why this is far better than the FFP3 mask. So the first thing is this. When you first put it on, there's the back of it. When you first put it on, there's your silicone part. It doesn't even feel tight. I mean, I remember when mine was fitted, I said, this is not tight, by the way. It's very firm, it's not tight, it doesn't need to be tight. It's molded to your face. I said, okay, it's very, very comfortable. The second thing is it has a speech diaphragm. And I'll put this on in a minute, and you'll still hear me, and you can still hear me talk to you. That's a speech diaphragm. The third thing that's excellent about this one is some of the respirators only have 2 inlet valves. So they have a patch here, they have a patch there. Whereas this one, when it came out, it has 4 air inlets. 1 here, 1 there, 1 there, and 1 there. So there's 4 entries for air. It's much easier to breathe with that. So first of all, you have the speech diaphragm, and you have the inlet valve. And this is what is the beauty of it. It has inherent in the mask a test function to test whether or not the integrity of the seal is intact or not. Okay, so I'm going to put this on, and I'm going to show you what's going to happen. Okay, I suspect you can still all hear me all right, yeah? Can you hear me okay? Yeah, I don't sound muffled to you. You can actually hear me all right. So what I'm going to do is I'm going to press, when I press this button,
Chris,
I'm going to be locked so that the air doesn't get in, which means...
Chris.
Yeah?
Hi. You've proved your point. So that's very, very good.
Okay.
The time, though.
Okay. I'm just going to demo the vacuum of it. So when I press this button, these inlet valves will be closed, and what will happen is you will see the mask suck into my face because there's a vacuum in there. Watch. Keep an eye on this rubber bit here. See? It sucks in there. Okay, the main reason why this is going to be the main thing is the cost involved. An FFP3 mask will cost between 10 and 15 pounds, and you use it once only, which means if you see 4 patients a day, in a week, it's going to cost you about 240 pounds. Okay. In a year, it could cost you about 11,500 pounds. Whereas this, 6 months ago, cost 35 pounds. Yeah. Now the price has gone up to 60 pounds, and you pay 20 pounds for the fitter to test fit it, which means in 80 pounds, if I wear this 8 hours a day if I wear this 8 hours a day, I have to change the filters once every 28 days. It's a massive saving. And the filters cost about 35 pounds. If I don't use it, I have to change it every 6 months. But you can see the different price. Okay, so I'll stop there and pass you on.
Thanks. You've made your point eloquently, and that cost saving was a particularly relevant point, I would suggest. So at this point, may I bring in Anthony Rowbottom? Anthony, could you bring us up to speed as to what's going on with the testing regimes, both for the active disease and for the presence of antibodies?
Okay, so it's a really interesting subject for an immunologist, a new virus coming onto the scene and one that we haven't seen before. So a lot of our understanding has been adapted from what we currently know about viral infections. And we know that there are different stages. So the first stage would be that the virus has to get in. And with this particular virus, we know that the spike proteins on the viral surface are the point of entry that the virus attaches and gets into the cell through the ACE receptors. The second aspect would be that the virus instigates a level of reaction, inflammation. And that's what you've probably heard of as cytokine storm. And that is a normal process. And in some ways it may be unregulated, but the production of a whole cascade of cytokines which have anti-inflammatory properties is a normal response. The second is that part of that response is to induce other types of cells. So the first set are B cells, and the B cells produce the antibody. And that's something that we're currently looking at. And the second phase would be a cellular response to look at lymphocytes, T cells. So in terms of the testing, we've got different strategies. So the first question is the virus present, yes or no? And for this, we apply the swab test. The swab test uses a molecular biology approach. To increase the sensitivity, we use a technique called polymerase chain reaction. And in essence, what we have are two very small pieces of DNA. That DNA becomes attached, and we can amplify across those two attached pieces of DNA. So we could start detecting one copy, and by the end of the polymerase chain reaction, the PCR reaction, we could end up with millions of copies. And that has the ability of increasing the sensitivity. So if we swab the nasal pharyngeal or we swab the throat, we are looking for the presence of the virus. What we know is that this is most effective 2 to 5 days post the onset of symptoms. If we wait too long before we do the swab test, then there's lots of dead virus which is being excreted and passed out through the nasal cavities. And as a consequence, you could end up with lots of false positive viral swabs. So the first phase then would be detection of the virus. The second phase, and this is one where we're actually moving into at the moment, is detection of antibody. And I'm sure you're aware that the presence of the antibody as it stands at the moment just indicates whether that individual has seen the virus and has made a response. We don't fully understand the level of protection that that antibody might give to subsequent infections. So the neutralizing ability of that antibody is unknown. And the reason that it's unknown is that when we produce an antibody response, we produce it to multiple parts of the virus. So lots of the current assays are directed against a structural protein within the nuclear capsid, and other assays are directed against the spike protein. Now, it's the antibodies against the spike protein are suggested to be the neutralizing antibodies and inhibit the entry of the virus into cells. But we just don't have the data currently to be conclusive about that. So at the moment, the testing strategy is, with the onset of symptoms, swab test to check whether the patient has got virus on board or not. Post those symptoms, and we have to leave it at least 21 days post the onset of symptoms to start investigating for the presence of antibody. And at the moment, we can offer swab testing with a turnaround time of around 24 hours from test to result. The antibody is much quicker. However, as I said, the value of the antibody test is yet to be established in clinical practice.
Okay, so is that, forgive my ignorance, is that test for the antibody a finger prick test, or is that, I missed that bit?
Okay, so at the moment, and this has been a lot of interest around this, because ideally it would be a finger prick test and we wouldn't have to set up the bleeding pods and phlebotomy services. Unfortunately, the sensitivity and the specificity of those pregnancy-style types of tests, lateral flow, isn't very good. I think we're looking at probably 65, 70%. So at the moment, the established PHE validated assays are all laboratory based, which obviously presents the challenge and a pinch point in terms of every sample has to be taken, has to be logged and go through to the laboratory. And the other challenge is getting the result back in a timely fashion. So currently, the direction is to travel to test all healthcare workers over the next 6 weeks. So for us at Lancashire Teaching, that is probably about 10,000 staff members. And that's being replicated against around all the 4 trusts. Within primary care, sorry, St. John, did you have a question?
No, I was going to ask Ian if I could ask you a question. Sorry, please.
That's right. So in primary care, that is just beginning to be addressed. So GPs are being asked whether they would enroll temporarily staff members at the surgery, and the test is being offered to selected patients who are currently having phlebotomy for other tests. So we are beginning to roll out the antibody test in terms of NHS laboratories. Now, for swab testing, there is an NHS body, NHS represented in terms of Pillar 1, and there is also the private sector in Pillar 2. And the question is whether the antibody is going to follow the same route as to when we start rolling it out to the community, whether NHS and healthcare workers will go through an NHS laboratory, and other health sector workers and community and social care will go through a pod and will go through private sector testing. Now, recently, we've had some stress tests across the NHS to see whether we've got the capacity to cope with that level of testing. And I think I sit on the national panel, and it's obvious that we have the technology and we have the capability to offer. For Langston South Cumbria, we're predicting somewhere in the order of 250,000 antibody tests. And most people will want them tomorrow. So that's the challenge.
Yes. Yeah, St. John, you want to ask a question?
Yeah, that's really fascinating stuff, Tony. For the audience who clearly dentistry is a high exposure business, as both Carl and colleagues have demonstrated. Are you saying that if we have an antibody test, as you've described, and we discover that we've got IgG, the secondary response antibody, all we can glean from that is that we've been exposed? Are you saying we cannot therefore conclude that we are protected?
I don't think we can be that categorical about it, purely from our experience from other viruses. So we know if you've got IgG to hepatitis, you're protected. So yes, the inference is there. What I'm saying is, at the moment, the evidence is catching up. All right, and I almost certainly I would suggest that the presence of the antibody will give some level of protection. It's just as to how effective it is. It's the same with hepatitis. We test, and whilst we might quote a figure, we don't really know how protective that antibody is. We just say that you have a level of immunity.
An antibody, yeah. Can I ask one more question, Ian? And it's to put Tony on the spot, so I don't have to answer any questions, really. Tony, and I recognise now this question will provide a personal opinion, and therefore we won't hold you to anything. But I guess your personal opinion outweighs anybody else probably in the region, I would have thought. What is your instincts about when a vaccine will be available?
I think within 12 months, St. John. The question for me is will the virus mutate, and how effective will it be? Now, the spike protein is relatively conserved, but there are areas that there is some level of mutation. But yes, I think around 12 months would be a reasonable time to expect a vaccine to be available.
Wow.
What I should say to the antibody question was that we've done a lot of gathering the data across the NHS, and what we know is that the seroconversion is about 10 to 20%, and that there are points of prevalence around the hospitals where the conversion is higher than perhaps you might expect. So in walled areas where there's a lot of PPE and a lot of protection, the seroconversion rate is quite low, whereas in other healthcare providers across the trust, the seroconversion rate is slightly higher.
So you're implying that individuals not wrapped up from their head to their feet in PPE are possibly gaining more immunity.
That's
I won't hold you to that.
No, but that's one possible explanation. But you've got to factor in a whole host of other things, social, economic, and there are a lot of things. But what we know is when we look across the hospital, there is a variation in the seroconversion.
Okay.
And one possible. Yeah.
Okay. Okay. So you're not advocating that we have measles parties or the equivalent. But,
no. I'm surprised by the low seroconversion rate.
Yeah.
Thank you. We've got a question come in about the possibility of putting hydrogen peroxide into the water line, whether that would be effective. I don't know who would like to pick up on that. I don't know whether it would be wise to put hydrogen peroxide in your water line, but
sorry, I'll go first, and then St. John, you haven't answered anything yet, have you? You haven't been asked any questions.
I just keep asking questions.
It's already done by some hygienists into their if they're using a Cavitron already. Certainly, they've used povidone iodine as well, and there's some research, but it's bacterial research that sort of looks at the difference in the efficacy when it comes to periodontal disease. I don't know about hydrogen peroxide. I suppose in theory, I can understand the logic behind it. But whether or not that's actually going to be there's any enhancement on that, and how detrimental it is to the equipment is another question. I think it's one for some research. There's no research on that. The research is really weak when it comes to dental aerosols as a whole. It's really, really poor. And I mean, one of the things that is being sort of bandied about is the research the fact that dental aerosols are so bad is the research was done, and it was done without using high volume aspiration, and it was looking at splatter, and it wasn't really looking at the dental aerosol as being the infective, or the fine particles as being the infective side of things. So I think that needs to be researched further, and hopefully we'll adapt, I would imagine, to the level of disease in the population, as Anthony was sort of talking about, in how we carry on with our PPE, and we go back to universal precautions with the masks and the visors, which seem really, really effective, and high volume aspiration when we're performing the aerosol generated procedures, or rubber dam if you can use it. You obviously can't use that when you're doing a scale or periodontal treatment.
Yeah,
I think one of the comments we ought to make really is what Chris was saying earlier, and I'm sorry to bring up the subject of indemnity, but I think you have to use a methodology which is within an SOP. Yeah. And I can't remember reading hydrogen peroxide in any of the certainly the BDA. Apologise, I've looked at the BDA slightly more in depth, and they certainly don't recommend peroxide there. And I think that's the key here. Don't step outside an approved protocol, as both Carl and Chris have mentioned.
Yeah, I think that's a fair comment. So are you aware of any other research going on in this field, St. John?
It's all going on in Anthony's lab up in LTH, most of it. He keeps asking me for bloody money the whole time. there's lots of work being looked at in terms of diagnostics treatments, everything from clinical diagnostic tests like X-rays, CT scans, research on, there were at the very beginning, Anthony, you may remember, there was a test about giving radiotherapy to the lungs to see if that worked. Donald Trump's got a whole research unit on bathing in Dettol, which seems to have gone a bit quiet. I think what's happened in the environment is lots of good ideas have come out. UCLAN have got a working with an institute down in Surrey called the Pirbright Unit Institute, looking at a synthetic polymers, with tiny little polymers, which are recognizing some of the spike proteins that that Anthony's talked about. And the idea is that you could have a swab which on it has got these little polymers that are recognizing the spike proteins, tagged with a fluorescent lamp, and literally in front of you, at the moment you take the swab, this thing would light up and tell you whether you've got a virus. But again, as Anthony talks about, its sensitivity is around 70%, 75%, which means you're getting 25% false negatives. So that is always the problem with these tests at the moment.
Yeah.
I think from our profession perspective, and Anthony, it's probably worth making a comment. I think this virus is here to stay for a fair while, unless it mutates itself out of the circulation. And in truth, from a profession perspective, normality depends, I would suggest, on a vaccine making its way into the system.
Yes, yes.
I totally agree, St. John. One other aspect we might want to consider is test and trace. That's going to have a significant impact on how we provide services. Within the trust at LHH at the moment, I think we've got 200 staff members who have been asked to self-isolate for 14 days.
Wow.
So that's something you can't predict, and will have a significant impact.
Yeah.
I've got a question for one of our students, actually, around what would be the effect of these aerosols and droplets, etc., on opening and closing drawers within your surgery? Because that's generally what we used to do, and not think twice about it, really. Is this another? Do we need to store our instruments elsewhere other than within the surgery unit? How would we cope with that?
I can answer that. In primary care, that's already been going for last 4 or 5 years. The document that we've had to go with, HTM 0105, basically tells you that everything within the surgery has to be able to be wrapped up, and you're not allowed to open instruments in your drawers anymore. So that actually, so even though COVID-19 is here, so the basic cross-infection control, you have still got to do all that stuff. And the only difference is we've had to add a few other extra things. So even like now, even without COVID-19, you're not really supposed to have any open instruments in your drawer, in our drawers at all. And you meant to take everything out before you need it. It's a real pain, and it takes a long time to get used to. And I would suspect there isn't one human dentist in the world, in England, that would be 100% following all that, because it's literally impossible.
Yes, quite.
I think as well that and from my personal opinion, I think the risk is quite low. I think the key is the triaging, which is all we can really do at the moment. I mean, Anthony, you might be able to help a little bit, but apparently, from what I've read, some of the research that was coming out was suggesting that the people that are asymptomatic but do have it are not very strong at actually shedding the virus. They're low viral shedders. Is that correct? You're muted, sorry.
You're muted, Anthony.
Yeah, that's absolutely correct. We know somewhere in the order of about 4 to 5% of asymptomatics will be carrying the virus, but they are low shedding.
So when you sort of look at the bigger picture and the extent of what we're doing and what we do as dentists, I think we're safe. Obviously, we're not safe, but we are a very, a pretty good place as long as we follow the protocols and understand them, and we should be okay. we're certainly better than the pub probably when they reopen. I'd be a little bit more worried about going to the pub and standing 1 meter away from somebody that was coughing than I would be going to my local practice.
Depends how thirsty you were, Carl.
Yeah, that's true. Yeah. Depends how many I had.
I think one of the big messages that, going back to Chris's point earlier, one of the big messages that we as a profession, we must get out into the public arena is we are taking our patients' safety very seriously, and we have to let them know. Sometimes if you don't have it painted in big letters above a door or on a window or on a piece, then you're opening yourself up to criticism. And I think that has to be a key message coming out, that every patient knows how seriously we're taking their safety.
One of the things I wondered, Chris, is you said you do your, basically you have your chat the day before and get as much of that out of the way, and also establish exactly what you're going to be doing on that visit. But I'm sure we've all been caught out by the patient who said, oh, while I'm here, would you just fix something else? Have you been caught out by that and had the wrong PPE on?
No, I haven't opened yet. We're opening next week because we will be opening on Monday. The main thing is your communication with the patient. So if they're there for that, then if they suddenly say, oh, by the way, this has come out, in which case it takes 2 seconds to, let's say they were in for a checkup at the end of the day, yeah? And they've got feeling, this is where I think it'll be perfectly justified to get your little glass ionomer, just air, don't forget the 3-in-1 is categorized as an aerosol if you use the air and the water together at the same time. However, if you gently press air alone or just water alone with your high volume suction, it is not categorized as a AGP. Okay. So what you do is you just dry the two, get your glass ionomer, stick it in there, and then you say, well, you'll just have to come back. The main thing is to practice saying these things in a non-authoritarian way, in a nice way, so that you have to practice saying certain phrases all the time. Now, I'm very sorry I can't do that now. Or for example, when I speak to the patients, I always start by saying the letter that we send out to our patients, it will start by saying, is it safe to come to the dentist? Yes. Outside of an operating theater, dental surgeons are probably have the highest level of cross-infection control, and you are in safe hands. And we are even adding additional measures to safeguard your safety here. And you have to psychologically get them to know that it's a safe place to come. And you have to hold your ground. Or for example, they're sitting in the chair and they say, my son just lost a filling. We will have to talk about that on the phone. And you just got to hold your ground for that.
Yes. Yeah. Good. Okay, I think that's been a very interesting and illuminating discussion.
Ian, sorry to interrupt. I did promise Shalini I would share a screen. Can I just do that for 1 second?
Thank
you very much.
It saves me remembering.
So I hope you've all enjoyed the presentation. I know I certainly have. I've learned a few extra things. So I'm just going to put this up as a screen to watch. I know that UCLAN are doing some more webinars, so you can have a little look at this. So we've got tips for clinical audit and rubber damology coming up with Shalini. Lovely picture, by the way, there. And then Peter Dyer as well. And then we've got Susan and Javid and Karen. Love you to attend these. I hope you've enjoyed this evening. I know I certainly have. I'm just going to stop sharing and I'll pass you back to Chris. So some blatant advertising there for UCLAN. There you go. Sorry. Ian, you're off.
Well, thank you very much. That's fine, and that saves me remembering doing that. So that's good. Yeah. So just to bring things to a close, really, and to thank everybody for their contributions, because that really has put things in context for us, and really makes it feel a little bit safer than we thought it was feeling. And I think, Chris, your advice around which respirator to buy is, because we've just done a costing on how much it's going to be to equip the students with disposable FFP2s and we're going to go through a shed load because there are a lot of students, and it comes to hundreds of thousands of pounds. So yeah, thank you very much for that. I think putting some context, Carter, the science was again useful, because that aerosol isn't quite such a scary beast as we thought. Yeah, and for the two eminent scientists amongst us who've really with the background.
That one.
Oh, he's over here.
Oh, I see.
No, thank you very much indeed, guys. Just a little bit of housekeeping. There is going to be a link, am I right, for the attendees to get their CPD certificates. If you fill that in at the end of the session, but do allow us a good month, 6 weeks to get the certificates back to you. But that's the only way you're going to get a CPD certificate, and that's via Nargis's email that she communicated to you. And I think apart from that, that's it, unless anybody else can think of anything. No? Thank you very much indeed, sincerely. Okay, and thank you for attending, everybody, and have a very good evening. It's rather...
Thank you. Thanks a lot.
Yeah.
Bye all.
Bye all.
Be safe, everybody.
Yeah, stay safe. Thanks a lot.
Be careful out there.